Thank you very, very much for taking some time with me this morning. I would like to ask one other question that wasn't asked in the general analytics, and I'll apologize in advance that it is blinding up here, so I can't see so well. But if you don't mind, I'm going to ask which into two primary camps you fall into within your organization. How many of you would describe yourselves primarily as producers of analytics versus decision makers leveraging the analytics? So how many people would classify yourselves as producers of analytics in your organization? Okay, it looks to me like it's around about 2/3. And how about consumers for decision-making purposes? Quite a bit fewer. Okay, so that's marginally disappointing to me. Not because I don't love you and feel a hope that you would let me be one of you, mostly because I have seen several organizations where there's actually phenomenal analytic talent, and the challenge is being allowed to use it. But maybe there are enough of you key decision makers here that you can go back and speak to your colleagues, and perhaps there's something that I can say up here that will help you with your leadership to leave your mark through the great skills that you have. Okay, so a few things that we're going to talk about in buckets. One is how it is that we think about AI as augmented as opposed to artificial, and why that's going to matter even more so, I think, for leadership than some of the other places where we may apply more advanced computational techniques. The other is to give you a sense of some of the really specific tools that you could take away and use that we're not seeing used nearly as broadly as I might hope in health and healthcare to support decision making. And lastly, give you a couple specific cases where you may be able to take this home and apply it in the short term. Okay, so the sections, why is it that we would even consider AI at the highest levels of leadership, and what does the world think about that currently? The two key things that I think of when I think about leadership decision making are being able to separate signal from noise on the one hand, we'll go through examples of that, and then also having a future orientation. Where do we want to go as an organization, and not just about beating people up for where we've been. Try to give you a little bit of a mind bender in terms of how far we might be able to take some of these ideas. So the first part will be a little bit more kind of traditional, and then we'll see how many of you would have considered the second application that we'll talk about, and then close on what's next. Okay, Kyle.
Here we are. Okay, poll question number 1. On a scale of 1 to 5, how likely is your board of directors or senior leadership team, if you don't have a board, to have a machine as a voting member by 2025? A, 0%, B, 25%, C, 50%, D, 75%, E, 100%, or F, unsure or not applicable. So this is a reminder, this is session 22. If you open up your app and open a poll question, this is question 1. I'll give you a couple seconds to respond. We'll pull up the results here.
Should see lots of thumbs engaged. Please.
Let's go ahead and pull up the results. We'll wait for some more results to come in. It doesn't look like we were getting a whole lot of...
Inconceivable. Inconceivable. So... Are we through? Is that everyone who's in this?
I think so, and I think it's people are really feeling like maybe it's a little uncomfortable to relinquish control or voting to a machine. That seems perhaps kind of a foreign concept.
Or there are 2/3 of people who need the machine to help them decide. So this isn't a totally random question. We'll see how your votes look like. Can we go back to the presentation? Thank you. So the World Economic Forum conducted a survey to see what tipping points would occur by 2025. So that wasn't a randomly selected year. And we have a list here of everything that people got to vote on. Internet-connected underwear, robotic pharmacists, those are kind of the same, 3D printed livers. at the very, very, very bottom of the list. And the only thing less than 50% likely, including we're going to all be paying our taxes via blockchain, the only thing is there is no way that AI will be on a corporate board of directors. And there are a couple of reasons why I find this interesting. So one is, what does surveys tell us about the respondents? So these were 800 executives. So maybe if we had asked in the room, what are the chances that we can have a robotic ED doc by 2025 in the Society for Emergency Medicine, maybe we would have gotten a similar response from them. And I wonder how many of them thought, yeah, but you can take my management and the computer can do that job, no problem. But the reason why I mention it here is because often our perceptions can become our forecasts, can become our realities. So if we don't start to ask ourselves the question and think about it deeply, there's a reasonable chance that we will make it so that we continue to underutilize analytics for health and healthcare leadership. So it's I think, a meaningful question for us to ponder. And why does it matter now? And a lot of you in the room raised your hands when I asked, are you producers of analytics? And if you've been doing it for a while, oh my gosh, is it easier to produce predictive models or reports or whatever in that space today than it was 10, certainly 20 and 30 years ago? So the computational horsepower has gotten better, the algorithms have gotten better. It's just a lot easier to produce these things today than it was in the past. It doesn't mean the rest of the problems have gone away. It's still true that today we spend 80 to 90% of our time hunting and gathering data. None of that has changed, unfortunately. But it's a meaningful point to start to have the conversation because the technology has gotten there where it's starting to become conceivable. So why do we need to think about it now? And who here saw the talk by the person from Google? So, and you remember there's the Google map, and maybe some of you have used Google Maps, and there was the analogy of how we can use Google Maps to help us get to where we want to go faster than we would have otherwise, right? Do we know where we want to go in health and healthcare? No. We need to have conversations about really where do we want to go and how do we want to get there. So now's a good time to start to have those discussions. Okay. This is a map that I think to many of you in the audience will not be that new, but I found it really helpful, especially for leaders, to be able to put all of these buzzwords that they're likely to hear on a page, and have to thank Anthony Chang, who's at Children's Hospital of Orange County, for putting this together and eagerly awaiting his book. He says he has a better version of this, and it's more descriptive in the text, but I don't have that book yet. So we see things in here about statistics, which is like really old and dead and useless. That would be me. Data science, really sexy and somehow completely different, except it was the same thing that I kept doing. And then we get things like deep learning, which everyone somehow wants, and yet we keep waiting for it to win outside of the unstructured space. So helpful framework, and AI Med, if you're not familiar with it, which is run out of CHOC, Children's Hospital Orange County. Really interesting thoughts coming out of there. So let's go to a practical use case here. And what is it that a board of directors or some other level of leadership needs to be able to do? And two key tasks, like if we think about what does an ED doc need to do? Make a quick diagnosis and disposition decision. What does somebody need to do in a management or leadership role? Needs to be able to separate signal from noise, and needs to be able to have that future orientation to take that information and decide where do we go from here. Hopefully not on their own. So, Kyle?
All right, poll question number 2. How effectively does your board or senior executive team leverage data to support future decisions? A, never, we don't look at the data. B, not often, mostly looking through the rear view mirror. C, frequently leveraging data and discussing interpretations. D, always, actively leverage analytics to drive decisions, or E, unsure, not applicable. So if you could take a couple minutes, again, this is session 22, question 2. We'll go ahead and look at the results here in just a sec.
I'm kind of feeling like maybe we should have left unsure, not applicable off the option list.
That was definitely a favorite in the last round.
I know, it was.
Let's go ahead and look at the results here.
Okay.
So it looks like we've got more of a normal distribution here. People are really feeling like they frequently use data to discuss interpretations and discuss decision making, and hopefully are looking to learn a little bit more on how they can make that more effective.
Cool. So one of my favorite people at Intermountain Healthcare, Alan Morris, used to say that we have to be adequately explicit in order to be able to have good discussions. And I wonder how you'll think about answering that question in context of the next couple slides. So what are some examples of separating signal from noise? Is one hospital better than another hospital? Are we getting better over time? Simple questions. If we set an improvement goal, is our target actually better than where we are today? Assuming that we were trying to improve, not just trying to sustain. And had a conversation with an organization just a couple weeks ago where they'd set this incredible stretch goal that turned out to be within the range of noise of what they were doing already. So believe it or not, these are not as trivial to answer as you might expect. Decisions about the future. Where do we think we're going to be in a year? Are we satisfied with that? If we're not satisfied, what do we really think we're going to do to change? And especially in healthcare, as we start to have that quadruple aim and staff burnout and work-life balance issues, is the change that we're hoping to achieve or sustain on the backs of superhuman and non-sustainable efforts, which I've certainly seen plenty of, and perhaps you have as well. So how can we reflect that in the basic kind of bread and butter reports that we might provide to a board of directors or any level of management, from the nurse manager up through medical office buildings or hospitals or some sort of senior executive team? So let's go through what we're seeing in this picture. And I think what everyone is kind of used to seeing is, so green is the direction of good, and the x-axis is somehow reflective of performance. So you want to be on the right-hand side. And hopefully, are we getting, okay, so we have on this side, direction of good is on the right. We have the individual points of performance. We have the blue line, which is the target. Is that working? Okay, awesome. We're trying to do the dual pointing. It turns out we're not allowed to have computers and mice to be able to touch the screen. Okay, direction of good on the right, points of performance, blue is the target. We have the system performance overall right here. And then we have 7 different geographies. So far, this is absolutely, totally standard quarterly reporting. In a visualization you may find aesthetically pleasing or in need of help. And if you find it's in need of help and know how, please let us know. And then we start to see things that are marginally different. So anyone know what these lines are here? The horizontal lines? Confidence limits, 95% confidence limits. So we're immediately starting to take our standard BI. Can I put a point on a page? Yes, I can, but can I give some sort of an indication of where might that point really be falling? And for those of you who are familiar with confidence limits, one of the things that might jump off the page is that some of them are a lot tighter than other ones. And why might that be? Oh, it's because these geographies are vastly different in size. Here we're talking about millions of members and patients, and here we're talking about a couple 100,000. And so just right there, we're interpreting things a little bit differently than we might have otherwise, because we're already giving people information which they would otherwise have to store in their head about how big are each of these geographies and really how certain am I about that point estimate. But then you might notice, and hopefully even if you're colorblind you can see it, that these points are actually different colors from each other. And if you're colorblind, you can also look on the far right-hand side, although it's a little hard to see, and wherever you see 2 letters that are different from each other, it means that those two geographies are statistically significantly different from each other. And if they share a letter, then it means that they're the same. So now we don't really have to ask ourselves if geographies 1 and 2 are really different from each other, or 3 and 4 are really different from each other. So 2 and 3 are different, 3 and 4 are the same, and then 4 and 5 are different. And again, it's removed that cognitive burden of trying to make those calculations in our heads, which I don't know a single human being who could. But more importantly, we've made visible for the entire group, really, I mean, they may disagree, but at least every one of us can read the letters on the right-hand side or look at the colors, and now the computer's saying, here are the differences in our organization, and here are where our organization geographies are performing identically to each other. Does that make sense? And what are we using to come up with these things? Standard stats, standard machine learning algorithms. For those of you who like machine learning algorithms, this is actually recursive partitioning that's separating out those points and telling us which points are really different from each other. Where do we use recursive partitioning? Or maybe you've heard of random forest. Readmission prediction, right? Case management selection. We use these tools all the time at the point of care and service. How many of you are using them all the time in your leadership and management decision making? A couple people. Thank you. I would love to talk further about how that's going for you and how you got to that point. So it's not nearly as ubiquitous in practice, but I would also ask you to consider how ubiquitous is it in people's thinking even? How can you imagine a manager coming to you and saying, an ED chief coming to you and saying, hey, I want you to build a predictive model for sepsis. But can you imagine that same leader coming to you and saying, hey, I want you to build a predictive model to help me understand where our performance is going to be in a year? I find the latter much less common, and yet the computers can help us there just as easily. There's one other point that you'll see, and these are the gray diamonds. What those gray diamonds represent is an automated forecast or projection of where these geographies will be in 1 year, according to the computer. And we've already, by having the confidence limits, by having the different colors of the letters, we've separated signal from noise. Remember, signal from noise is there's two geographies really different from each other or not. We've answered that question. We've removed that cognitive burden. We've helped everyone walk away with a common perspective and interpretation of the raw data, even if they don't agree with the results. At least we've made it visible so that we can have that discussion. But now we get to that future orientation, because what you'll see is that as a whole, as a system, we're actually getting better, and in a year expect to be right around our target. And our top performing geographies are actually getting marginally better, not changing, maybe getting slightly worse, but basically they're staying put. We're seeing a couple geographies that are improving pretty quickly, and that's wonderful to see. So now, what's the question that we might ask those two geographies? Before, we might have looked at this report and said, you idiots, why can't you perform? Now the discussion changes, and I've seen this myself in a boardroom. Now the discussion becomes, yeah, I mean, you're underperforming right now. We're really excited about your improvement. Is this sustainable? What's going on in your market? What's happening with your staff? How are your resources doing? Are you actually going to be able to achieve the trajectory that it appears that you're on? And it totally changes that discussion. What's the other thing we're seeing? I mean, one, we're seeing a lot of variability by geography, and we'll talk more about that in a moment. But who's actually projected to get worse? It's our lowest performers. How would you like to be a member or a patient here? What's the organization doing to rally around you, where we have a couple things going on? And I don't know the answer in this case, but it just so happens that our smallest geographic units are struggling the most, and actually not just falling behind as others accelerate, but actually projected by themselves to get worse over time. What are we going to do differently about that? And again, maybe someone stands up in the audience and they say, no, 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 but I know why that is. We had some temporary blip and we're not really trending worse. We just had an aberration with the data, or we had a strike, or we had something else happen, and we're going to recover and we're going to be fine. Okay, that's okay. But now we've been able to have that conversation together. We're on the same page together. We're able to move forward, allocate resources together for the betterment of the organization as a whole. And we're using exactly the same techniques that we do for point of care and service predictive modeling and forecasting. So we've gone through these questions, but hopefully you can see how we can use these techniques to answer standard management and leadership decision makings to help the organization move forward. The part that spooks people the most is the forecasting. I'll be totally honest about that. That people are okay with confidence limits. They're even okay with the tell me which two groups are really different from each other. And they're totally spooked by forecasts because how can the computer figure out where we're going? I know much better where we're going as an organization. And so for those of you who are more analytically oriented or the producers of analytics, I just wanted to make sure that you knew that there's actually a really, really solid body of evidence out there about how well computers do at forecasting. And I've left some links in there for you if you would like to take a look later. For those of you who are in leadership positions or will be in leadership positions, please know this has been studied extensively over 40 years. And every single time the computers blow away the human experts. Does that mean that the computers never make mistakes? No. We know our predictive models fail at the point of care and service as well. So I don't want to be cavalier about it. I just would like to reinforce the idea that this is an area where computers actually do quite well. The other thing, if you are an analyst, is there's nothing, the cool thing about forecasting is it's actually possible for most human beings to be able to look at a forecasted data. So the blue part is the actual, the orange part is forecasted. And so if you do find yourself in a circumstance where you're questioning the forecast, it's relatively easy to show to most humans who can look at the forecasted data and say, yeah, I believe that or I don't believe that. Very difficult, by the way, for human beings to imagine these dips in the future in the midst of general upward trends. And if you've not seen this in real life, for those of you who work with HCAHPS or hospital experience data, seasonal. Seasonal by number of patients in beds, seasonal by their experience, highly impacted by things like remodels and changes in menus and things like that. It can be really helpful to have the computer providing some guidance, just as it is in the ED or in care management or do not shows in our clinics. Okay, so we're now going to go to what I wonder, I kind of hope, or at the same time kind of don't hope, that this might be a little bit of an unexpected application or maybe even a little bit of a mind bender for you. So, quality. We've had what I find to be and others find to be a very useful definition of quality on 6 dimensions. It was put out by the Institute of Medicine quite a while ago. And it tells us how is it that we want to think about quality. And the last one on the list, which I kind of wish wasn't the last one on the list, but after safe, effective, person-centered, timely, and efficient, we get to equitable. And what does equitable mean? It means that the quality of the care that we deliver does not vary on the basis of personal characteristics like gender, race, ethnicity, geography, and the like. Have we already seen a violation of equity in this today? Right, we had geographic variation, huge quality differences based on geography. That's what we hope not to see. So we have this definition that's out there. The AARHQ page I find particularly helpful and compact for carrying around in my wallet, so I never forget it. So now, Kyle.
All right, poll question number 3. On the subject of health equity, how do you assess or address healthcare equity in your system? A, we don't. It's not a priority at this time. B, a health equity group that discusses opportunities. C, a scalable quantitative approach to finding opportunity. D, formal equity, evaluation or optimization embedded inside of major initiatives. E, other, or F, unsure, not applicable. So we're going to try something different. We're going to pull up the results right now so we can see people's results flooding in here. Let's take a look at that. We'll give you a couple more seconds. A reminder, this is session 22, question 3. Give you 3 more seconds to respond here. So it looks like we're suffering from the unsure bug again.
Mm-hmm.
You know, looking at this, I'm kind of surprised. I would have expected the majority to be on B, a health equity group that discusses opportunities. It looks like, you know, there are a large percentage of people that are actually having data-informed discussions about health equity. You know, obviously, a lot of people might be unsure about how that might apply to their organization, but it's different than I would have expected.
Me too. A show of hands, who knew that equity was actually a dimension of quality according to the IOM? Okay. So not everyone. This isn't what I expected at all, actually. I would hope health equity is one of those sort of strategic and, if you have it, highly communicated focuses of an organization in order to address it. So if you're unsure, that's almost one of those spaces where the answer is probably not. It's hard for me to imagine an organization that has a secret focus on health equity. Yes. And maybe because you have no inequities in your systems. I guess that's the possibility then. Okay, so if we could go back to the slides, please. What we're going to do next is see how we can apply those same tools and techniques that we use in data science, AI, machine learning, and specifically turn them. You know, currently there's some question about, and it's a legitimate question, is AI going to perpetuate biases and inequities and make them worse in our society? And it's absolutely possible. But it's also absolutely possible that we can turn those same tools around specifically to support decision-making and understanding around where we have equity and inequity. So let's see what that might look like. How many people have seen this map before? Not the map of the world, I mean, but the map of the Gini coefficient. Hopefully everyone's seen the map of the world, a couple people. Okay, so let me just describe briefly what we're looking at here. There's something called the Gini Index. It is a measure of the distribution of wealth within some unit, and in this case, the unit is a country. So it's not a question about whether people, because you see reds and greens unless you're red and green colorblind, and I apologize. So the darkest reds are sort of in southern Africa, and the brightest or darkest greens are sort of in the Scandinavian countries. And so that's not asking the question, does somebody in South Africa make more or less money than somebody in Sweden? The question that it's trying to answer is, what's the relative distribution of wealth within a country? So is there more inequity within South Africa than there is within Sweden? And the answer is yes, there is. In fact, South Africa typically rates the worst in terms of economic equity. And I saw a couple people laughing. I feel like I should somehow strike Ukraine from the best country, not because I disagree, but oh my gosh, I've had a couple Ukrainians come up to me after showing them this, and they're saying, you know, you're an idiot. I'm like, I'm not the idiot. The CIA and the World Bank is the idiot. I'm just reporting what they said. But, you know, explains to me why the measure is completely stupid. Or the collection of the data is completely stupid. So most of us would be okay with Denmark being up at the top of the list. But the basic idea is the larger your Gini, the more inequity you have. So we have South Africa up there at, is it 0.63? And we'll stick with Denmark so we're not offending anyone at 0.29. So the smaller your Gini, the greater your inequity. Does it make sense so far? So now what's the problem with applying this in health and healthcare? As a general rule, is it ever a bad idea to have more money? And if you'd raise your hand, I will come around and help you with that problem. Yeah. So generally speaking, if we're thinking about finance and economics, more is better. We can measure what your income is, and we feel pretty good about that as being an index. What would be the analog in health and healthcare? Right? I mean, how many measures do you guys produce reports on to somebody out there routinely? Tens, hundreds, usually hundreds of measures. How do we think about how we're doing in hemoglobin A1C control in our diabetic patients, right? Which is one measure of how it is that we're delivering health and healthcare, versus readmission rates in patients who have had a stroke. Both are reasonable measures, and they're both really important to you if you're either diabetic or you've had a stroke, and completely irrelevant to you if you haven't. So in health and healthcare, we don't have that single measure that anyone is willing to stand behind. We'd like to have something about global health or something like that, but we don't have that today. What we have is an abundance of measures. So what if instead of ranking countries, we ranked our performance on our measures? And most of the data are not fabricated, but the measures have been obscured. So we had a couple hundred measures. We throw all of them into the hopper. And again, instead of using the country as the unit of measure, we're using the measure as the unit of measure and asking ourselves, how equitably are we able to deliver performance on this measure? And now we have a Gini ranking of every measure that we have in our organization. How might we use that? Well, now we can see where something like hemoglobin A1C control, highlighted in yellow there, where hemoglobin A1C control rates in terms of where we're able to achieve equity. And the thing is that it's relatively high on the list. It's not the top thing on the list, but it's relatively high on the list. This went on for like 100 or so measures. You'll be glad to hear that the measures at the bottom, so where we had the greatest equity, were in pediatric measures, so it's good. I mean, if you have inequity, you would rather it not be in our kids, right? If we get to choose. So that was good. But we can now rank every single measure just like we could rank every single country. So now we have some insight into, okay, if we're going to have health equity as a focus for our organization, where might we focus? And in this case, hemoglobin A1C control might be a reasonable place. Most organizations I'm aware of have a particular dimension that they choose to focus on about health equity, and the most common one are racial ethnic differences. That's where we would like to really see equity improved. So how did we get to Gini in the first place? Well, there's an algebraic relationship between things like the area under the receiver operating characteristic curve, which some of you will go, I know what that is, and some of you will go, I have no clue what you just said. The area under the receiver operating characteristic curve is a measure of how well we can predict an outcome. So just like we can predict who has severe sepsis or septic shock, who's going to die, who's going to get readmitted, who's not going to show up for their clinic visit, on and on and on, we can predict how well will we be able to control hemoglobin A1C across our population. But now we're going to change it. So now, if we have a readmission model, we try to create that readmission predictive model on the basis of complication of medications, because then we know what to do about it, right? We can go and say, ooh, you need a pharmacist consult, or you need a nurse to go through and do a teach back on your medications or something like that. So we build predictive models using things that we hope to some degree are modifiable, or at least diagnostic for us. So all we're doing in this case is we're building the predictive models that we wish failed. We wished we could not build a predictive model on the basis of your race, your age, your gender, your geography, or something else. So again, it's the exact same tools. And if we frame it as the predictive model that we wish that we couldn't build, now we have our whole predictive toolbox open to us, including things like feature importance. What is contributing to our inability to be able to have uniform achievement of hemoglobin A1C control? And the answer is age. So if as an organization we said, equity is really important to us, and we think we are not able to achieve hemoglobin A1C control as we would like to across our entire population, and we're going to focus efforts on improving equity on race, ethnic divisions. That's a laudable goal. The only challenge is that's not the problem for this organization. The problem for hemoglobin A1C control is age. By the way, how many people think it's the young people who have good hemoglobin A1C control? A few. How many people think it's the old people? We're not really sure on that one either. It was the old people do really, really well. It's the young people who we struggle with. So if as an organization we had committed to improving health equity, and we really wanted to do something about race-ethnic differences, it's a little bit of an eye chart, but hopefully what leaps off the page to you is right about here. Here's our race column. And this is the longest bar that we have in here, and it's still relatively high up on the list of overall inequity in health and healthcare. But this is the place where we have the single biggest contribution based on race and ethnicity to a health-related outcome is this measure right here. And that measure is antidepressant medication, but specifically in the space of continuation. So we're okay at initiating the medication, we're not good at continuing the medication. And now we have an approach to help the organization focus. The cool thing here is this particular organization had a massive focus on improving mental health and wellness. They've just had two major strategic goals come together. Okay. So we will breeze through this and then open it up for your questions. We focus a lot of time and effort around AI at the point of care and service, and I'm glad that we do. I think the opportunity is at least as great, if not greater, in the space of making the large management and leader decisions that we have in health and healthcare to achieve the quadruple aim. We have tools in our belt to be able to pull out. You do, in this audience, have the tools in your belt already that you know how to use to facilitate these decisions. And my hope is that your leaders will support those efforts. So thank you very much. And we will now have time for questions or comments, by the way. Thank you.
Let's get to the questions. Sorry, I'm having a little technical difficulties.
Yeah.
So the first question, kind of the top polled question, how far are we from a vendor product that helps non-technical analysts build predictive models by importing a data set without required technical coding or advanced data science knowledge?
Sure. So there are several tools out there that will help build predictive models. That's not really a problem anymore. I don't see that as a problem anymore. The problem that we have is on either end of building that predictive model. So if I think about effort, sorry, I'm just going to put this here. If I think about effort that's required, here's the amount of effort that's required to build a predictive model. Here's the amount of effort that's required to prepare the data to feed into the predictive model. I won't even talk about things that we don't even capture, like general well-being or something like that. So we'll leave that alone. But this is just how hard is it to feed the data into the model. And then we have the how hard is the change management to take advantage of the model that we just built. So if you find yourself struggling to literally pour data into a model and come out with a reasonable predictive model on the other side, please come talk to me, and happy, there are both health catalyst solutions, non-health catalyst solutions. There are a lot of solutions to solve that problem. And if I've misunderstood your question, please raise your hand and we'll clarify.
All right, well, next question. What would be your 30-second elevator speech to an executive that's kind of weary of machine learning or forecasting techniques?
Oh, 30 seconds.
Would you push the button on the elevator?
I might stand in the way. So I would be curious on this one. I don't think it would have anything to do with technical. If there's an organization that's struggling, it could literally be asking the question instead of the 30-second speech, asking the question, what decisions, if any, are you struggling with at the moment? If the person that I was in the elevator with was particularly impressed with themselves, I might take the route of, other organizations are really pushing forward with their ability to use AI and ML to support leadership and management decision. How comfortable are you that we're a leader in that space? So I think one of those, depending on whether there was space in me and the ego in the elevator, I don't know. Yeah.
I always like to have my problem statement kind of, it tweaks based upon the audience, so I could see that, yeah. What are a few tools one could use to help move leadership more towards machine learning and AI?
So the first thing is, I don't know any leaders in health and healthcare who don't want to use AI and machine learning. They just don't want to use it for their decisions. They really want it used for other people's decisions. So the question I would rephrase a little is, how do we get them to want to use it for their own decisions? I don't know about you. I mean, there are a lot of organizations represented in the room. I think there is a little bit of reaching that point of overload, and I don't know what to do differently to achieve our organizational objectives anymore. Truly, I am running out of options, and I have seen this start to reach that tipping point as an industry where our leaders truly now don't know what to do. And that's a great opening for us to come in and try to help. So I think that's something to take advantage of. The other is that I would encourage you to find somebody in your organization who is a supporter and leverage them and their connections to try to influence their peers. I have seen a very, very large organization pivot in its approach to using data on the basis of a change in a single board member, and being able to then, you spend so much time, those of you who are producers of analytics supporting your organization, you spend so much time trying to do it at the grassroots level. Ask yourself whether there's somebody that you can reach out to very near the pinnacle of the organization who can push down for you. And if you can find such a person and such an advocate and such a supporter, it will be much, much easier.
So once you get the people and the tools, but if you're a new organization, where would you start applying some of these methods?
If you're a new organization?
New organization to AI.
Oh, if your organization hasn't used AI, perhaps. Like you're not a startup, but more
brand new to the AI world.
Yeah. So here's the cool thing. Much of the work has been done for you already. This is more of an application or engineering problem. You don't need to reinvent the wheels. The tools are freely available out there to you. If you have questions about how would I apply it or how would I use it, please reach out. Maybe you can tell I'm a little bit enthusiastic in this area, and I would welcome the opportunity if truly you're just struggling with, gosh, how do we get started technically or from a thought process, would welcome that discussion.
And how can we build leadership's trust in predictive modeling and forecasts into major decision making?
It's the last part that's the key, and we've addressed this a couple times. They trust it completely when it's making decisions for docs and nurses and pharmacists and EVS and everyone else. It's only for themselves that I really find that they're questioning it. So I feel like we've kind of addressed this from a couple times already, but one thing I would say is leverage what you know from doing this at the point of care and service. Be very transparent, be very honest, point out the shortfalls yourself, and be humble when somebody points out something that's wrong yourself. The same approaches apply. We're human beings at the end of the day. When someone goes from being an ED doc to an ED chief, they're still a human being. When that person then becomes a CMIO or becomes a CEO, they're still a human being. Most people will appreciate transparency and honesty, co-creation and collaboration, and the solution together.
Now, I hope I get this question right, because in the Gini model,
Yes.
we had, I think, age and gender.
Yes.
And there was one more column.
We had age, gender, geography,
And geography.
region. Yeah.
Do you know why? Or were there additional factors?
Yes.
Because the one question was, why would poverty level not be considered a factor?
Oh, so that's a wonderful, slightly more technically oriented thing in a way. So one of the cool things that we do in the point of care and service predictive modeling is you build a predictive model, and then someone comes up to you and says, well, how come you didn't consider this other factor? And what do we do in that circumstance? We say, oh, great idea. Let's add it and see what changes. And sometimes the answer is nothing, and sometimes the answer is a lot. And then we go forward with whatever the best model was, right? So if someone says, ooh, I want something in there around socioeconomic status, it could be level of education, or we could have primary spoken language, or we could have anything. Not a problem. Not a problem at all. For that matter, we can have some other risk adjustment approaches out there. We can add whatever we want to the predictive model, just as we would at the point of care and service, and then again, look at the same outputs. How does that change our overall ranking for how it is that we're thinking about our ability to achieve equity? If we add primary spoken language, level of education, income, whatever, if that reshuffles our overall ranking, wow, that's good to know. And if we have, that must also mean that they're contributing in different ways. And if we want to go after something that has to do with primary spoken language or something else, now we know where to focus. So that's great.
Great. How about, do you find it beneficial to predict an outcome first in order to build a leadership's confidence, followed by forecasting approaches?
I'm not sure I'm completely grasping that one. So as a general rule, I think about forecasting as being applied in aggregate. Where is this measure going over time? And I usually pull out the predictive tools to look at something more granular than aggregate, more granular levels. And so there's probably something there that I'm not totally understanding. I'm sorry. So if you have a question about that, I know I haven't answered it, but please come up and we'll discuss it.
Do you think that the mandated policy will impact AI and machine learning in the future to either bring geography dispersed units towards or push them further apart from AI unit leaders? That's a meaty question.
Where are we?
Right here.
That mandated policy. I don't think I understand the question. So, again, and are we really supposed to be stopped? Because up here it says 3 minutes.
Yep, we got
okay.
a minute.
Okay. So that's another one where I'm afraid I'll have to understand the question better. And I don't know, do we want to take the mic out into the audience and try to clarify, or what do we want to do?
With the person that kind of submitted that question, let's just ask for a little clarification.
Yeah.
And let that be the last question, if that's okay, and we can call you out. If nobody wants to stand up, we can just ask another question. All right. Let's ask another question.
Okay.
Let's see. I'll let you pick. Let's see. Why don't we just do you see that organizations are struggling to understand differences between machine learning and AI?
Yeah, I struggle to understand the differences. So, yeah, I think it's really murky. It's why I threw that one map out there of the different terms that get jostled around. And Anthony Chang's book, I hope, will help us a little bit specifically in the health and healthcare space. The part where for me I focus the AI discussion is I do use augmented rather than artificial, and I immediately focus on what are our values and objectives. And that's not something that you typically discuss in machine learning. So for me, there's the technical underlying substrate, methods, processes, but where AI for me becomes different is I don't want to start an AI discussion until we've had a discussion about what are you trying to achieve, not like what is your outcome that you want to predict, but really as an organization, what are you trying to achieve and what are your values? What are you thinking about in terms of trade-offs in achieving your goals? And then for me, it becomes augmented intelligence, because now I've understood your perspective, I've understood where you're trying to go and what you're willing to do to get there, and now I can augment that with a whole boatload of techniques, much of which fit under the name of machine learning.
Well, we're at times.
Okay.
And Jason, thank you very much. Let's give him a round of applause.
Thank you.